Hello, this PowerPoint is going to be covering meningitis, encephalitis, and headaches. First, let's go over some anatomy of the spinal cord. So first you have the spinal cord, you have nerve roots, and you have meninges. So we're talking about meningitis, is talking about your meninges. So there are different layers. You have number one is your dura mater. It's the outermost membrane and the thickest, and that can feel pain. Your second layer is your arachnoid mater. This is the middle layer and includes a network of fibers and collagen that helps protect the brain and the spinal cord from a sudden impact. And then your most inner layer, number 3, if I can write today, is your pia mater. It's the innermost layer, hugs the spinal cord like a coat, and it has blood vessels that deliver the oxygen. So it provides nutrients to the spinal cord. Meningitis is the inflammation of the meninges, which is that connective tissue surrounding the brain and spinal cord. Some common causes will be your virus or bacterial. It can spread to the bloodstream from other infections like cellulitis, pneumonia, or from a traumatic injury of the facial bones. Can also be secondary to invasive procedures or devices, and can be a complication related to Lyme disease or an opportunistic infection from AIDS. Usually starts somewhere else, such as the respiratory tract, and then enters the blood and then goes into the central nervous system. Bacterial is fatal because antibiotics are needed to resolve, while viral usually goes away on its own in about 10 days. Some signs and symptoms. The usual initial symptoms are severe headache, fever. Then later you can get photophobia, which is the sensitivity to light, a petechial rash that can go from petechial to large areas. That is usually seen in meningococcal meningitis. Nuchal rigidity, which is that stiff, painful neck. That's a classic sign. That's usually what leads the doctors to think that it's meningitis, is that stiff, painful neck. They could have positive Kerning signs or Brudzinski signs. It can also have nausea, vomiting, and they can have some restlessness and irritability. Fever is also one of the first main signs, and usually that does remain throughout. Optus thummonis is an involuntary arching of the back. That can also be a sign. I have posted this video online or on Blackboard for you to watch, so you don't have to wait for it to load on your PowerPoint. I have loaded this video on Blackboard as well, so you don't have to wait for it to load on your PowerPoint. So some complications would be seizures. It's because areas of the brain are becoming irritated. That you can have cranial nerve damage or occasional permanent neurological deficits, and this is usually related to the increased intracranial pressure, which we will talk about later on. Viral usually has no lasting effects. Some other complications would be your visual impairment, deafness, hydrocephalus, a subdural effusion, brain damage. endocarditis, pneumonia, and septic shock. Some diagnostics test would be a lumbar puncture. This is usually the key diagnostic test. With a lumbar puncture, your bacterial will be cloudy with a decrease in glucose. And the reason for the decrease in glucose is because the bacteria actually uses that sugar. With a viral, you're going to have clear, elevated white blood cells. You will have a normal glucose. They can also, if it's a bacterial meningitis, they'll want to do a culture and sensitivity. And this is because the culture tells us what bacteria it is, and sensitivity is going to tell us what antibiotic it's sensitive to. They can also perform a CT scan. It can show if there's movement of the brain content. It can also rule out other concerns if they're concerned of any kind of brain tumors or anything such as that. Some therapeutic interventions would be antibiotics. That's again only for your bacterial. You can give antipyretics, cooling blanket. This is going to help lower the fever. You can provide a quiet, dark environment, and analgesics to help with the pain. Corticosteroids, they're going to decrease swelling. Antiemetics is going to help with that nausea, vomiting. And we want to provide, they will be in isolation for because they could possibly be contagious. So meningococcus meningitis, especially on isolation until 24 hours after medication, because that is spread through the nose and the mouth. If a family member or someone that you have become in close contact with has meningitis, they will give you a prophylactic treatments. This can also include your Cipro, Rocephin, but it's an antibiotic. Also, prevention would be your vaccines. You want your pneumonia vaccine, meningococcal vaccine, Hib vaccine. Those are all going to help get rid of those, prevent you from having those viruses that are going to cause meningitis. Now we're going to switch over to talk about encephalitis, and I put a picture on here to show you the difference between meningitis and encephalitis and what exactly is the difference here. With meningitis, it's going to swell the meninges, which is around the brain. With encephalitis, it is swelling of inside the brain. So encephalitis, it is the inflammation of the brain. This includes the spinal cord. It can be caused by a virus, such as the herpes virus, upper respiratory infections, measles. It's rarely a reaction to vaccines, but there has been some known cases that has linked it to vaccines. It can also be caused by lead poisoning, chlamydia. It can also be caused by your insect bites. So those are going to be mostly your mosquitoes that commonly have West Nile virus. The most common include the vector-borne or complications from viral infections such as the measles. Those are going to be your two most common. So your onsets kind of look a lot like meningitis because you have that headache, a sudden fever, nausea and vomiting, and the nuchal rigidity, which is that stiff neck. Later on, you can have confusion, decreased level of consciousness, develop seizures, photophobia, ataxia, hemiparesis, tremors, coma, and even death. So you got to think of encephalitis as kind of like compartment syndrome. So think of the skull. The skull doesn't really expand like other body parts can expand as swelling happens. Well, the skull doesn't move. So what happens is it gets to a point where it winds up herniating the brainstem or the cerebellum, which can result in your permanent damage. So some complications, that would be your cognitive disabilities, personality changes, ongoing seizures, motor deficits, and blindness. So think about that. We're putting pressure on the brain. And if you go back from our day one, look at what all does the brain do. Some diagnostic tests could be a CT or an MRI. It shows the brain tissue. An EEG shows your brain activity. And a lumbar puncture is going to show clear cerebral spinal fluid, increased white blood cells, a normal glucose, and it could show an increase in the immunoglobulin M. So most of these are going to determine if there's inflammation in the brain. So let's talk about some preventions and interventions. So how are we going to prevent? The biggest thing we can do is the prevention of bug bites, as that's one of the most common. So we want to pay attention to the incident rate viruses in our community, such as is there a high rate of West Nile virus. We also want to avoid outdoors at peak mosquito biting times. We want to wear clothing that covers as much skin as possible. You want to apply repellent, and this is going to be on the skin and clothing. Replace windows, clear gutters, empty things that can hold water because that's going to draw those mosquitoes to you. You also want to place netting around your strollers and car seats to prevent your child from getting mosquito bites. Some interventions, those are pretty much the same. The biggest thing is we're going to try to provide symptomatic care. So do they need a Foley because they're not voiding? Do they need an enema or a stool softener? Those are the things we're going to make sure we're providing a good oral hygiene. We're going to provide skin care, frequent position changes, oxygen as needed, monitoring our I&Os because if they are dehydrated, they could possibly be constipated. We're going to prevent problems of immobility by turning and providing range of motion exercises. May have slowed speech, so we need to make sure that we provide them time to communicate. Lastly, we're going to talk about headaches. There are 3 primary types of headaches, which are your migraine, tension, and cluster. Migraine can be unilateral or bilateral, meaning it can be on one side of the head or both sides of the head. It usually is caused by changes in serotonin receptors, and that promotes dilation of the cerebral blood vessels and pain intensification. And that is from neurochemicals released from the trigeminal nerve. So here they're going to have pulsating headache, severe, associated with nausea and vomiting, photophobia. They can also describe this as a throbbing or bursting. They can also have vertigo, irritability, and fatigue. There are many things that can trigger migraines. Your tension type headaches is related to a persistent contraction of the scalp, facial, cervical, or upper thoracic muscles. So this is usually associated with stress and is usually bilateral, meaning it's always, when you have them, you feel it on both sides of the head. They describe this as pressure or a steady constriction. There is no pulsating. The pain is usually mild to moderate. It is not associated with nausea or photophobia. And lastly, you have cluster headaches. There's no known cause of what causes the cluster headaches. It is usually unilateral, mostly seen more in men than women. And they usually say this is excruciating unilateral periorbital headache, which means they're feeling the pain behind their eyes. It's also associated with conjunctival infections, nasal congestion, facial swelling, and tearing and redness of the eyes. This can occur up to 8 times a day, lasting 15 minutes to 3 hours. A big thing here is this usually awakens the patient from their sleep. So instead of wanting to lay down in a quiet environment, you usually see these people pacing the floor, but they don't usually lie still. Some triggers could be alcohol, histamine, and vasodilators. So some nursing interventions we're going to talk about is keeping a diary, and they're going to keep a diary of their food and their headaches. So we're going to record any triggers, the timing, how long did they last, what symptoms, what were you doing prior, and was there anything you did to help the migraine. We also want to teach relaxation and stress reduction. Key management to migraine is you're going to avoid triggers, modify their diet if needed, maintain a regular sleeping schedule, maximize stress coping mechanisms, and they're going to try to avoid oral contraceptives and avoid medication overuse. With tension type headaches, you can, most of these will take over-the-counter drugs such as your aspirin, acetaminophen, or your anti-inflammatory with combination of caffeine. They can also, if those don't control it, a lot of people will put them on antidepressants. A lot of physicians can put them on antidepressants, which also helps decrease tension headaches. Physical therapy could be included for proper attention to your posture, usually related to work, and how to loosen up the neck and shoulders so you're not tense, causing those tension headaches. Cluster headaches, you want to avoid the triggers. For an acute cluster headache, we want to provide oxygen. Usually with cluster headaches, you're going to see physicians give an IM or an intranasal route just because they work faster. Again, we want to make sure we're keeping a calendar or diary. Overall, they're going to avoid triggers. Medications, that's going to depend on what type they have. We want to reduce the stress. With migraine and tension headaches, you usually want to try to provide a dark, quiet room and teach them exercise and relaxations. And we also need to make sure they're aware of when to contact their healthcare provider.